Yes, I'm Robert Freeman. I'm councillor at Kensington, Chelsea, and my address is the Town Hall, Horton Street, London, W8.
If you turn, please, to volume 1, which should be in front of you.
To the microphone.
Oh,
Is the microphone not on?
I think there's a button. That one goes green for some reason. But
Is that okay?
Yes.
I'm so sorry.
Volume 1, if you look to page 359, to 366, it's the last document, in fact, in that.
Yes, that's mine.
That's your submission. Is it true to the best of your knowledge and understanding, and do you wish it to stand as your evidence to the Commission?
Yes, I do.
I wanted to ask you, please, first a little bit about the consultation phase. Do you have any view about whether the proposals which were put to consultation were adequate?
I think that's a very difficult question. I sometimes had the feeling that there was an answer waiting to be given, and that answer was expected of us rather than it was a completely open consultation.
So was it your view that starting from a reduction of 9 to 5 major hospitals was an adequate consultation, or perhaps too circumscribed?
I think it was, I wouldn't say circumscribed. I think there was a certain expectation that the proposal would be approved.
What awareness, what level of awareness in your locality was there amongst members of the public about these proposals?
I think very little.
And could and should more have been done to engage the public? And if so,
well, it's always very difficult. You can always do more. But I think the reality is that the public don't look at the fundamentals of healthcare. They look at their own needs in terms of, if I'm ill, how can I be treated and where can I go? They don't actually say, if there are closures, how is that going to affect me? And let me to carry on, if I may, we're different from Westminster. We're different from Hammersmith and Fulham, because Imperial, although it is a major provider for our residents, there is no actual Imperial facility within the Royal Borough.
Now, your submission, you say you're standing back from voicing views about individual hospitals, but I wonder if you're able to clarify your committee's position on the baseline proposition that the reconfiguration should involve a reduction from 9 major to 5 major hospitals.
The reduction really that concerns our residents more than anything else is any possible downgrading of Charing Cross Hospital. Our residents, in terms of general acute care, if one can use that term as opposed to specialist acute care, are served mainly by St Mary's and the Chelsea and Westminster, and to some extent Charing Cross, and particularly for emergency care in terms of stroke, cardiac, and some elective procedures such as cancer. In the Marsden, obviously, is the major cancer provider, together with Brompton in terms of thoracic and lung cancer, but the 2 major hospitals for us are St Mary's and the Chelsea and Westminster.
So is it the case then that it wasn't something that your committee considered, whether or not the baseline proposition of from 9 to 5 was appropriate or not?
I think what concerned us more than anything else was how St Mary's and Chelsea and Westminster would cope with the additional burden. And I think we were particularly concerned with the effect of the closure of the hyperacute stroke unit at Charing Cross and the move to St Mary's. We were concerned by the poor state of Imperial at St Mary's and to a lesser extent Western Eye Hospital, although Western Eye Hospital is likely to close anyway, and for the specialist departments there to move to St Mary's. But the difficulty we had was understanding where the funding was going to come from to make a major change to St Mary's Hospital, which would be essential in order to provide for the closure of Charing Cross. But so far as closing or downgrading Charing Cross and moving it to St Mary's, that was not a major concern for us as such, provided that the new St Mary's, if I can use that term, was able to cope with the additional burden put upon it.
Now, you've raised the issue of finances, and in your submission you raised some of Imperial's problems. And I think it's at paragraph 2.2, at the bottom of 359 and 360. You suggest that there will be a need for substantial funding. And can you help with your understanding of where that substantial funding is to come from?
Well, I have discussed it with Imperial, and to my view, the only reasonable solution is the money comes from a Treasury loan, because in terms of PFI, I've had a fair amount of experience with PFI hospitals. They can work, and the largest one I think going on at the moment is the Royal Liverpool University Hospital, which is something like £500 million. But I don't think that would be a good model for St Mary's. I think St Mary's needs to get Treasury funding, probably by loan, in order to carry that out.
And what, if anything, is the relevance, do you think, of the sale of the land on Charing Cross, the proposed Charing Cross land sale?
I've no idea how much it can raise. Obviously, it's a very large area, but you have the problem that you need to bridge it in any event, because you'd have to keep Charing Cross Hospital open for quite some time while you were upgrading the estate at St Mary's.
So a degree of uncertainty.
A high degree of uncertainty. High degree of uncertainty. Imperial is not a foundation trust. It obviously, since the CQC report, it's put back its plans to become a foundation trust, and though the financial position there has strengthened considerably from 2 or 3 years ago, it still is not a strong financial trust. Mind you, what a strong financial trust is these days is hard to say. Most of them are facing considerable problems with the tariff and with earning enough money to build up reserves.
I'm just thinking a little bit about the impact on Chelsea, Westminster and St Mary's of the closures at Central Middlesex and Hammersmith Hospital. You say, we know that they were both, St Mary's and Chelsea and Westminster were both assessed as needing improvements by the CQC. In your view, was the poor assessment of the CQC in any way related to impact of additional influx of patients from the closure of the two accident and emergency wards?
I think it's always very hard to say what the causes are, but we've been through the CQC report, the action plans, carefully, both ourselves and also with the trust concerned. And I don't think there has been an appreciable increase in the accident and emergency waiting times or referral times to treatment from the closure of Hammersmith A&E. I don't think that's a major factor.
Is there a risk, if there are further closures, or albeit slightly further afield, that more pressure will be put on those services?
Yes, of course, but Chelsea and Westminster is undergoing a major refurbishment and increase in capacity of its A&E department, which I hope would help to cope with that. St Mary's, the emergency department, A&E department, is very near capacity, and I would be concerned that without more investment, that could be a problem.
And in terms of the move of the hyperacute stroke unit, you say that you and your committee question the decision-making about placing it at Charing Cross for such a short time. Can you expand, please, on exactly what you mean by that?
If we said that, I don't think that was what I meant to say. What we are concerned with the decision to open a hyperacute stroke unit at Charing Cross, which is now faced with the possibility of closure in order to gain proximity from the major trauma unit at St Mary's. And what we are questioning is whether the decision was right in the first place to have the hyperacute stroke unit at Charing Cross rather than at St Mary's. I mean, I've been in the hyperacute stroke unit as a patient It is an outstanding facility, and one that plays a major part in ensuring the health of patients within this area.
Do you have any comment on the move to St Mary's in terms of the impact it may have on residents who live further out in the borough?
Well, my strong belief is geographical proximity is not nearly as important as an ability to offer high-grade patient care, and it's a sort of everybody's interested is now well aware that your blue light ambulance will avoid one particular hospital and go to one a little further, because the patient care there for the particular requirement is so much higher.
Does it follow, therefore, that efficient transport routes are a priority?
Efficient transport routes are a priority. An efficient ambulance service is a priority. London Ambulance Service has suffered very badly from a leakage of highly skilled paramedics. They're conducting a campaign at the moment in Australia to try and encourage more paramedics to come to London, but clearly that isn't going to solve the problem immediately.
You raise in your submission as well a number of areas where you say you would have liked to have more information or detail, and these are broadly a clear outline about the effects on people with comorbidities, future plans for specialist services at Charing Cross and plans for the site, need for an examination of allocation of funding to midwifery and commitment to appropriate expenditure, and more detail on the out-of-hospital improvement works. So looking at those together, while those questions remain unresolved, does that give rise to any degree of uncertainty about whether the decisions that are currently being taken are correct?
I would say that there really are two factors that worry me particularly, in a way possibly more than that. First is the uncertainty as to exactly what an urgent care centre is. I think the need to educate people onto how to use health services. We need a stronger signposting which has to come through the GP surgeries. I'm concerned about the smooth working together of adult social care and acute trusts. I'm worried about the discharge process, and I'm worried about our own ability as a local authority to provide good home care reablement to people coming out of hospital. Unless you can deal with those, then I think you have got problems, but they're not just problems that arise from the closure of any particular hospital. I'm also concerned about the equalities aspects of this. Many of our residents have poor English, and I think we will need to educate them very carefully about how the system works now and how it will work.
Would it be better to have more complete information, if possible, on these kind of things before taking any irreversible steps?
I think it's essential.
I just want to ask you very briefly about the maternity aspects, because you commented on the omission of factoring in freestanding midwifery services. How serious, in your view, how serious an omission is that?
I think it is a serious omission, but my view is what we really need to do is to improve in-hospital midwifery services. I think that is the need. And in fact, with the CQC report, the midwifery services at Imperial were rated good, which I think is very encouraging.
And I wonder, even though it's not in your borough, do you have a view about the planned closure of the Ealing maternity unit?
No, I have no view on that. It's really outside our realm or knowledge.
Now, finally, I just wanted to ask you about the social care end of things, if I can call it that. If that isn't fully financed and functioning and up and running, what are the implications for the increasing use of primary care?
I think it's absolutely vital, and I am disappointed because I had thought the Better Care Fund was going to be used for linking up hospital discharged patients with social care, but the emphasis now seems to be far more on reducing hospital admissions. I think that, my view is that's the wrong end. It should be used for better discharge rather than decreasing hospital admissions. But a good quality social care service is essential, in my view, to alleviating some of the problems that we see in the National Health Service. We cannot afford to have patients who can be home, should be home, and would be far happier home, still in hospital, because there is no way of allowing them to go to a home that's unsuitable for them.
Now, assuming that some of those services will come from the local authority, what further information do you need on the financing of those social care services to be able to assess the implications of the services provided by RBKNC?
I think we've got a pretty good handle on it. What I would hate to see is that there are further cuts in funding from central government that make our task more difficult. And if I may say one point you haven't talked about, which concerns me enormously, is the provision for mental health, particularly acute mental health. And I think that is a problem which won't go away, and something that we really do have to address locally and nationally.
And what effect do you say that the omission, my omission, but the omission of that from the Shaping a Healthier Future programme, what effect does that have on the validity of the programme as a whole?
We are treating more of our mental health patients in an acute setting, and I think that is not desirable. We're sending, so I gather, although I've asked for a report on it, we're sending more patients who are sent to a place of safety under sections 135, 136 of the Mental Health Act to an acute setting. I think that's extremely undesirable. We have 72 hours in order to treat a patient like that, and I think that wasting time in an acute setting is appalling.
Is it safe to further cut or reconfigure acute services whilst the financing and the arrangements for out-of-hospital hours remains unclear?
I think you cannot reconfigure until you know first that that reconfiguration is practical, and secondly that that reconfiguration is possible. And it's only possible if you have the estate and you have the money to provide that. Estate in terms of the land, and you have the money to provide the physical estate. You cannot possibly safely close highly specialised and effective and safe units unless you know that those can be reconfigured elsewhere.
Do I have no more questions? But if you'd like to wait there may be questions from the commissioners.
Yes, thank you very much. Well, I have a simple, straightforward question, I hope. And therefore, is the plan safe? In other words, the plan out of hospital, care in the community and so forth, is this safe at the moment? Because it's happening right now, apparently. Is it safe?
It could be safe, but it isn't safe. And it can only be safe if we know how it's going to be implemented. You cannot have a plan unless that plan includes an implementation strategy. And I don't believe we have that at the moment.
I just wondered if you could say a little bit more about the mental health point that you made, because you talk about the people being sent to the wrong type of unit, to acute unit, rather than, presumably this is again the question of provision of these services in the community, more community-based mental health.
I think it's a very big subject, and I'm sorry, I probably started a hair running, which maybe I shouldn't, but it's much more complicated than that. It involves clearly the police, who are the force that intervenes when people require to be taken to a place of safety. I believe the police in our borough are extremely good at taking people to a suitable place, but we need to establish that always happens. Certainly, to take a 135, 136 patient to an acute setting, or worse still to a police station, is appalling.
Are you working with local trusts in order to try to...
We're working with the local we certainly, our own social workers, we put a very high priority on this. We had a working party on it, which some people call a task and finish group. I prefer a working party. We looked at it in depth. We looked at it with the police, with the local mental health trust, and with our own social workers. And it's something which I think is vitally important.
So do you feel this is sufficiently recognised as a priority when we're talking about the broader questions of your country?
It is where we live. It is in Westminster, Kensington, Chelsea and Hammersmith and Fulham. I can't really say what happens elsewhere, but I mean in some parts of the country, not in this part of London, it is an appalling state of affairs. But I think we're coping here.
Just a comment about working relationships. We heard from Councillor Lukey the difficulty you had working with the Imperial Trust. You mentioned that following the CQC report, you worked closely with the Trust, CQC reports on presumably St Mary's A&E. What kind of working relationship do you have with the providers?
You mean with Imperial or Chelsea?
Just generally.
We have excellent working relations with the trusts, and we talk to them, we have frank discussions with them. We've been through the action plans with them, with the CCG, and we have commented and suggested alterations to those action plans, and I'm satisfied that our concerns have been listened to, are listened to, and that we can work together in order to make the health provision in the secondary and tertiary sector very much better.
That was precipitated by the CQC report. I mean, how closely have you discussed shaping a healthy future?
Well, we of course are responsible as local authorities for looking at reconfigurations of the health service. But in our main role as a local authority, I believe, is to be the patient's voice. And post-Francis, it's something that we've taken extremely seriously. We've had public meetings with Imperial, with Chelsea and Westminster, with the Royal Marsden, and I believe we have a very good working relationship with them. We have councillors who are actually on the Council of Governors at Chelsea and Westminster. I'm on the Council of Governors at the Royal Marsden, have other councillors at Brompton. We take an extremely keen interest in what goes on. We don't with the Imperial for two reasons. First of all, Imperial comes under the Trust Development Authority, not Monitor, so we don't have representatives there. And again, we are not a host to one of their facilities, but we talk regularly to Imperial. They came to our last scrutiny committee a week ago, and I go and see them and talk to them, and so does the cabinet member. And I think we do watch very carefully. We also analyse patients' complaints, which I think is a vital part of being the patient's voice. We look at the way that the complaint system is organised, and I feel we do help to shape the way that they operate. I mean, if the question is how far have I felt engaged in shaping a healthier future, I don't feel terribly engaged in that. I feel, in a way, it had a momentum which we had probably inadequate input into how it was going to go forward.
Yes, sir.
You say you didn't feel particularly engaged with the shaping a healthier future, but you previously also, very interestingly, raised the question of the Better Care Fund.
Right.
Where clearly you are supposed to be more engaged, but you talked pretty much as if it had been steered in a direction you don't agree with. You say, you think, and I think you're probably right, that it should be focusing more on discharging patients with support into community settings and home and whatever, rather than stopping or reducing the number of emergency admissions. but do you feel it's now been effectively steered
Well,
in that direction?
far be it from me to get involved in political points,
I'm
but
making
the better. I'm a politician, a very low-grade politician. I had always been under the impression that the Better Care Fund was to be used to integrate or join up, awful word, the way that the acute trusts worked with the adult social care, particularly adult social care. It seems to have been steered away by central government far more, and understandably, if you look at the pressure points on the health service towards decreasing hospital admissions, and there are incentives in order to see that done. My personal opinion is that is unfortunate.
Thank you. I'm looking at the time slightly, well, quite a lot in fact. I'm sorry we've overrun. Before I let you leave the building, in view of your very good working relationship with providers, could I urge you to, on our behalf, go to those providers and ask them in the next few weeks if they would closely cooperate with us, because we're having difficulty getting documentation and answers. Is that something I can ask you to do?
I will try, but I think you overestimate my ability to influence them, but I will certainly try.
Judging from you today, I don't think so. Thank you very much.
Thank you, sir.